Hi everyone, this is Renee, and in this voiceover we're going to talk about fractures and joint replacement. Okay, so before we get into fractures, we're just going to do a review of bone. So bone is classified as dense, irregular connective tissue that's made up of osteoblasts and osteocytes. The purpose of bone is to provide support and structure to the body and also to assist the body in movement and protect vital organs. Now we're going to move into fractures. So a fracture is defined as a disruption or break in the continuity of a bone. Fractures occur when there's too much force placed on a bone, and therefore it fractures. Fractures are most common in the young and the elderly populations, and that's because both of these groups have porous bone that contains areas of weakness. The geriatric population is also at higher risk for fractures because they have that bone density loss due to the aging process. So any disease process that weakens bones or decreases the bone's tolerance to force is going to increase their risk for fractures. So the most common type of fracture for people ages 12 to 21 results in high energy trauma. So those are the types of things that include motor vehicle accidents, contact sports, or bicycle accidents. Now, people over the age of 65 typically have fractures that are results of low energy trauma, and that is a result of their bone density loss. There are different types or classifications of fractures, and the first one you will see here is a complete fracture, and this is when the break goes completely through the bone, whereas an incomplete fracture, the fracture is partially across the bone, and there's no displacement of bone fragments. You can see these on both the right-hand side of the picture on your slide. A closed fracture or simple fracture is when the skin is not ruptured and remains intact. Whereas an open or compound fracture, the skin is broken and it exposes the bone and causes soft tissue injury. There are different grades of the open or compound fractures. Grade 1 is when there is simply just a puncture wound, but no vascular involvement with the injury. Grade 2, there is still that puncture wound, but fragments of the bone are coming out, and there is moderate skin and muscle contusion and significant wound contamination. A grade 3 is the most severe grade, and this is when there is severe damage to the soft tissue, nerves, muscles, and blood vessels. This grade is extremely contaminated. You can see the open and closed fractures on the left-hand side of the picture on your slide. There's also different patterns of fractures. So a transverse fracture is a specific type of broken bone where the break is at a right angle to the long plane of the bone. The transverse fracture most often occurs as a result of strong force being applied to the long axis of the bone. An oblique fracture occurs at a 45-degree angle across the cortex of the bone. Oblique fractures tend to occur on long bones like the femur or tibia. A spiral fracture is next, and a spiral fracture is it wraps around the shaft of the bone. A spiral fracture occurs due to rotational or twisting force. A comminuted fracture is a break or splintering of the bone into more than two fragments. And since you need a lot of energy and force to fragment bone, these types of fractures are usually a result of high impact trauma, such as an MVA. An avulsion fracture is an injury to the bone in the location where the tendon or ligaments that are attached to the bone when force occurs. The tendon or ligaments are pulled off, and a piece of the bone comes with it. An impacted fracture occurs when the broken end of the bone is jammed together by force of the injury. Next is a fissure fracture, and this is when one or more fine cracks penetrate the cortex of the bone. Lastly, we have green stick fracture, and this is when one side of the bone is broken and the other side is bent. This type of fracture is usually seen in young, growing adults. Displacement is minimal, and healing is usually pretty rapid. Continuing with patterns of fractures, so we have a compression fracture, and that happens as a result of excessive force, leading to the bone collapsing in on itself. It is commonly caused by bone mass loss, often seen in osteoporosis, that occurs as part of an aging process or also from falls from a significant height. The next is a depressed fracture, and this is when fragments of the bone are forced inward. This typically results from blunt force trauma. The depressed fracture is commonly seen in facial and skull fractures. We have two more patterns of fractures, and the first is a displaced fracture, and this is when two ends of the bone are separated from each other and out of their normal position. This type usually occurs during comminuted or oblique fractures. Finally, we have non-displaced fractures, and this is when the periosteum remains intact across the fracture and the bone is still in alignment. You will commonly see this with transverse, spiral, and green stick fractures. All right, so now that we've discussed fractures, what they are, the different types and patterns, we're going to move on to management of fractures. And fractures are typically diagnosed with an X-ray and sometimes a CT scan. Also, rarely an MRI may be used to diagnose. Treatment options are going to vary based on the type of fracture it is. Some will need surgical or non-surgical management, which we're going to get into later in the slide. But generally, fractures will require pain management, which will be a combination of narcotics and anti-inflammatory medications. Also, if the fracture is an open, contaminated fracture, antibiotics will often be prescribed to prevent infection. The most common non-surgical management is a closed reduction, which is a procedure that lines up the ends of the broken bone and segments, and they're usually manually manipulated and realigned. After the closed reduction, there is a cast or splint placed onto the extremity to prevent any movement of the realigned bones. Moving on to surgical management, the first one we're going to talk about is open reduction with internal fixation. This is commonly referred to as ORIF. In this procedure, the surgeon opens up the area and can visualize the fractured bone where first they're going to reduce it. So they're going to align it, and then they will typically use some sort of hardware to keep it in place. So plates or screws may be used. The next is external fixation, and this is the application of a series of rods and pins in the surrounding area of the fracture. So they go above and below the fractured bone, and it creates a frame or stabilization that's going to align the displaced fragments. External fixators are frequently used when there is significant soft tissue damage at the fracture site. Because there is no cast, it does allow for that swelling to happen without the fear of compartment syndrome. Another treatment option for fractures is traction. Traction can be used with other treatment options as well, and it involves the use of weight and force to reduce the fracture and relieve any muscle spasms that may occur. There are two different forms of traction. There is skeletal traction and skin traction. Skeletal traction uses pins, tongs, screws, and wire that are surgically secured to the bone and then attached to a wire with weight hanging on the end. Skin traction, on the other hand, uses a flexible harness or boot or belt on the outside of the skin, and then the weight is attached to that boot or apparatus to apply that weight and force. So there are, of course, complications that come with fractures. We're going to talk about compartment syndrome first. This is a serious condition that, if it's left untreated, can actually lead to the loss of the affected limb. Compartment syndrome occurs when there is an increase in edema and hemorrhage in the compartment space. Increased swelling compresses the blood vessels. It restricts the blood flow and oxygenation of muscles and nerves, and this leads to tissue hypoxia. This hypoxia causes more blood and fluid to leak into an already restricted compartmental space. This is a vicious cycle of neurovascular compression that can progress to permanent damage and eventually loss of the extremity. The nurse needs to perform frequent neurovascular examinations, and that includes assessments of both the affected and unaffected limbs. The key findings include pain out of proportion to the injury and pain with passive movement of the affected limb. The nurse must utilize these key assessment skills using the 6 P's of extremity examination and notify the provider of any abnormal findings. Typically, the healthcare provider will remove the cast, and sometimes they may even have to perform a fasciotomy for compartment syndrome. Some other complications from fractures can include neurovascular compromise, and typically this is done during the trauma. When the fracture actually occurs, a bone fragment will sever the vessels and also the nerves around that area. So compartment syndrome, which we discussed earlier, the nurse is going to assess for neurovascular compromise using the 6 P's. The next complication is a venous thromboemboli, and a venous thromboembolism. And this is a condition in which blood clots form, and this often occurs in deep veins of the legs, groin, and arm. And this is known as a deep vein thrombosis, or DVT. These clots will travel in circulation, and they usually lodge in the lungs. And this is what's called a pulmonary embolism. When this happens, the emboli clogs the pulmonary vasculature, and it stops the normal gas exchange and impedes upon oxygenation, and that can lead to respiratory failure or death. Signs and symptoms of a PE include dyspnea, tachycardia, abnormal breath sounds, pleuritic chest pain, cyanosis, anxiety, and altered mental status. Another major complication is fat embolism syndrome. So this is really similar to what we just went over with the venous. Only exception is that fat is what's causing this clog. So when there's a fracture in the long bone, sometimes particles of the fatty bone marrow will migrate into the circulatory system, and this fatty emboli can cause a block anywhere. So just like with the venous, it's going to be specifically hazardous if it goes into the pulmonary cavity, and it can cause a pulmonary embolism. Another complication is hypovolemia, or low blood volume, and this is caused from blood that is lost during the fracture, and it is common with open and closed fractures. Also, the pelvis is highly vascular, so it is likely that if a client has a pelvic fracture that involves damage to any vessels in that area, that they're going to go into a hypovolemic shock, where the body is trying to compensate for this low blood volume. It is very important for the nurse to monitor for vital signs for anyone with a fracture, because it will allow us to monitor for hemodynamic stability. Another major complication of fractures is infections, especially for open fractures. In addition to any open fracture, anytime there's pinning or external rods that are used for traction as well, they can increase the risk for infection and osteomyelitis. Osteomyelitis is going to be covered in one of the other voiceovers. And finally, we have malunion and non-union. Malunion is just how it sounds, basically. So when the two fracture pieces do not line up accordingly to an anatomical position. And this can cause musculoskeletal problems in the future, especially in regards to muscle function and gait function. Non-union is when the two fractured pieces fail to heal, and it can be from a number of reasons, including overuse of NSAIDs or age. Moving on to nursing management for fractures. So the first thing we're going to do, of course, is an assessment. We're going to do assessment of the 6 Ps, which again include pain, pressure, paralysis, pallor, paresthesis, and pulselessness. We're going to compare the neurovascular assessments from previous assessments, and we're also going to compare them to other extremities. This is very essential. Vital signs will indicate hemodynamic stability, positioning of the affected area, labs, and we're going to pay special attention to the CBC for the hemoglobin and hematocrit, and the white blood cell count. Nursing actions will include administering prescribed medications such as pain medicine, antibiotics, and anticoagulants. And if it was an open fracture, there may be wound care or pin care may also be needed. Ice and elevation will help reduce inflammation. Range of motion and positioning. Some teaching interventions include discussing treatment options available for the client. The healing process. We want to discuss a specialized diet that will promote healing. And again, wound pin care, often the client will have to go home and care for their own wound, or another family member may need to be taught how to care for it. So education about exercise and ambulation and the use of assistive devices such as crutches, and self-care such as ADLs that may need to be adapted. So now we're going to move on to joint replacement. So joint replacement is also called total joint replacement, or TJR, and arthroplasty. This is commonly associated with joints of the hip and the knee, but it can include any joint within the body. It is a surgical procedure that repairs articulated surfaces with synovial joints. A new surface is then restored during this procedure, and the artificial joint usually lasts about 10 to 15 years. All right, so pathophysiology of joint replacement. So osteoarthritis is a leading clinical need for joint replacement. What happens is there's a loss of cartilage strength and function, and there's erosion of cartilage and bone. There's also a narrowing of the joint space, and this produces bone spurs and thinning cartilage. The inflammatory response enhances the deterioration, and the result is joint destruction, joint dysfunction, and deformity, which is going to lead to immobility, pain, muscle spasms, and localized inflammation. The way to fix this is joint replacement, and this involves removing the damaged area of the bone and replacing it with a prosthetic. The replacement of the joint can be either partial or complete. Moving on to medical management for joint replacement. So the diagnosis is based on deformity, destruction, and loss of function of a specific joint. The need for joint replacement is confirmed through either an X-ray or MRI. Treatment is conservative and aimed at weight management in addition to activity modifications and joint supplements. When those are not successful, then joint replacement is usually recommended. Surgical management includes many different options. The two we're going to go over here are cemented or glued option. So the prosthetic is cemented or glued onto the remaining joint or bone. This is typically used with older adults that will not need a replacement. Then there is uncemented, where a prosthetic is fitted perfectly into a hole that is drilled onto a bone, and then eventually the bone growth will hold it in place. This is for younger or more active clients, and that will likely need a revision at some point. So, of course, there is complications related to joint replacement, like everything else. The initial complications that can happen will be either intraoperatively or immediately post-op, and they include hypotension, bleeding, and hypovolemia, and these are all due to excessive blood loss. The other complications that can happen after the client is stabilized can include infection, either infection from the wound or infection of the bone, which is osteomyelitis. Using aseptic technique and proper hand hygiene, this is imperative to prevent infection. Dislocation of the prosthetic joint is another complication, and assessment findings for this include pain from the client, and you can also see in the picture that the legs will be different lengths because of the dislocation. Deep vein thrombosis and pulmonary embolisms are also complications and are the most life-threatening complications of joint replacement. Okay, so post-operative nursing interventions for joint replacement. Again, we're going to start off with an assessment. You're going to assess the client's level of pain in addition to their vital signs and any lab values that will help you determine their hemodynamic stability. Neurovascular assessment is going to include the 6 Ps and assess for the wound drainage, looking at the consistency, the color, and the amount. Nursing actions will include administering any pain medications, wound care, mobilizations, passive range of motion of the affected extremity, and positioning. We're also going to use compression stockings and administer any anticoagulants to try to avoid DVTs. When it comes to education of the client, you're going to provide your client pain management education on anticoagulation therapy, and teaching about diet modifications. We want to tell our patients to avoid any foods that are high in vitamin K, and this is so they don't interfere with the anticoagulants. We will also provide home management education as well.